So in the previous episode, we introduced the EEG, and today we're going to discuss the other very common neurophysiological test, and that is nerve conduction studies. Just as in with the EEG, a person that's not working in neurology doesn't have to have an intimate understanding of nerve conduction studies, have a basic understanding who to request the nerve conduction study for, and also how to interpret the result is useful. So when we talk about nerve conduction studies, it's essentially us stimulating and recording nerve impulses along the body to assess the integrity of the peripheral nerve or the peripheral nervous system. There can even be changes in patients that have neuromuscular conduction issues or even in myopathic patients, but typically we're looking at the peripheral nerve. We could be assessing individual nerves. Example, a patient has a carpal tunnel syndrome and we're assessing just the median nerve. Patient has a foot drop, we want to assess just the peroneal nerve. But often we're testing a combination of the nerves to look for a polyneuropathy or multiple nerves that are affected. When we do our tests, we can do both sensory studies and we can also do motor studies. When we're assessing the integrity of the nerve, we get different values that we compare to the normal ranges of values. Specific things that we're looking for, we're looking at the amplitude, we're looking at latencies, we're looking at nerve conduction velocities, we're assessing for conduction blocks, and a couple other more complicated things. When we look at these specific values, we can try and isolate if we think there's an issue with the axon or the myelin of the nerve. So is this an axonal process, a demyelinating process, or maybe a mixture of both? So when we look at the amplitude, a reduced amplitude is in keeping with axonal damage, whereas latency, nerve conduction velocities, and conduction blocks are typically related to demyelination. So essentially, when we get a patient, we have some standard tests that we do, or actually we always start off with a clinical exam first, just having a clinical idea, because the nerve conduction studies is actually an add-on to the clinical exam. We don't just blindly do a test, we always just clinically assess. If we actually feel like this patient has only upper motor neuron signs, maybe this actually is in keeping with the myelopathy, with the dermatomal sensory loss, we actually won't proceed with nerve conduction studies because that is not assessing the central nervous system. We're only assessing the lower motor neuron syndromes. So we will do a clinical examination and then decide what tests that we're going to do. Typically for the upper limb, our two standard nerves that we do is median and ulnar. If we think the radial nerve is affected, we can also do radial nerve. If we think that there's a problem with the brachial plexus, and that obviously becomes a bit more of a involved and lengthy study, then we also can assess the lower limbs. Typically, our standard studies will include the peroneal nerve and then the tibial nerve. Different muscles will be tested for each of these nerves. So who should get a nerve conduction study? So any patient that has a suspected peripheral neuropathy may benefit from a nerve conduction study. If a patient just has a sensory neuropathy and maybe even just pinprick and temperature is affected and JPS and proprioception vibration is intact, you might actually not pick up any abnormalities in nerve conduction studies because small fiber neuropathies are sometimes not actually picked up in terms of abnormalities. But once a patient has weakness and stuff, then most commonly we will find abnormalities. So any patient that has a peripheral neuropathy, isolated mononeuropathies, suspected brachial plexus lesions, suspected radiculopathies, all can get nerve conduction studies requested. But again, always confirm that they are primarily lower motor neuron signs, which would justify us doing the test. Other special ones that we can do in patients that have neuromuscular junction issues like myasthenia, we can do repetitive nerve stimulation, and that's specifically looking for decremental responses at a muscle, and that's in keeping with fatigability that we see in NMJ disorders like myasthenia. As I add on to nerve conduction studies, we can also do needle EMG studies, and this is when we put needles into specific muscles, and we can look for neuropathic changes, we can look for myopathic changes, and we can also look for features of renervation or active denervation. And this basically adds to our nerve conduction studies when we're trying to localize or come up with an etiology of a problem. So typically then when we report on our study, we can report on a normal study. That's one thing. So we can say normal nerve conduction studies. And again, if there is clinically some sensory loss, that just might be keeping it with a small fiber neuropathy. Then let's say we have a mononeuropathy, a carpal tunnel syndrome. We might say, nerve conduction studies is in keeping with a pathology of the median nerve at the wrist, and clinically this might be in keeping with carpal tunnel syndrome. So we might diagnose a mononeuropathy. we might diagnose multiple mononeuropathies. That could be in keeping with like a patient that has like a mononeuritis multiplex. But typically we're diagnosing polyneuropathy being multiple nerves affected. So we'll often comment on whether this is length dependent or not. So length dependent implying that the lower limbs are more affected than the upper limbs. We'll comment if it's sensory motor, just sensory, just motor, or a combination of both. And then we'll comment on whether there's primary axonal or demyelinating features. Like I said, axonal features will be primarily reduction in the amplitude, whereas demyelinating features are mainly prolonged latency, reduced nerve conduction velocities, and the presence of conduction blocks. And the specific criteria that patients have to meet to say that they have primary demyelination. So in our summary, we'll list all of that there. And essentially that then will guide the specific workup. If it's axonal polyneuropathies, that has a specific workup. If it's demyelinating, that has a specific workup. Typically, that workup will be guided by us, because the minute you have patients that have severe peripheral neuropathies, we probably would get involved at least with the workup and the management. However, certain conditions that are purely medical, like say a patient that has lupus, we may pick up an axonal polyneuropathy, and maybe it's medicine's job just to make sure to exclude other causes, and that way it comes to the list of causes of axonal polyneuropathies. That's just a quick summary of nerve conduction studies. Prepare your patients, tell them that it's not the most comfortable test. It's not like an EEG or ECG where it's completely painless. We wouldn't call it specifically pain, but it is discomfort when you get stimulated with that impulse, especially with the motors. We sometimes do have to go a bit high, and it can be a bit uncomfortable, but at the end of the day, it's always patient science consent, and they can always ask us to stop midway if they really can't tolerate it. So we'll basically give impulses, we'll measure the nerve integrity, decide whether it's multiple nerves, single nerve, axonal, demyelinating, and that essentially will guide the workup going forward.